Hi guys, Dr. Greenspoon here. Welcome to your preoperative education class. The purpose of this video and PowerPoint is really to give you some information and review some details and what to do and expect in preparation for your upcoming hip or knee replacement. The idea behind this is to allow you to be able to watch this as many times as you want from the convenience of your house, and hopefully will answer the vast majority of the questions that you have. These slides will be available on my website along with a list of frequently asked questions that I recommend that you print out and you can take some notes upon and also reference those. We will be scheduling phone calls the week before your surgery for about 5 to 10 minutes for you to go over any questions with me and discuss any unique situations that you may or may not be experiencing. So please sit back, relax, and hope you guys are ready to learn about hip and knee replacement. We will be reviewing the knee anatomy today, so we'll spend some time reviewing the knee anatomy as well as the compartments of the knee, what arthritis is, and how I treat arthritis with surgery, whether that be with a partial knee replacement or a total knee replacement. We will also review hip anatomy and review the contents of what a hip replacement entails. We will then transition and spend the vast majority of the time speaking about what to do in preparation for surgery, reviewing my medication protocol, reviewing physical therapy, as well as some frequently asked questions, and then once again reviewing the risks and complications that we may encounter with surgery and what we can do together to help decrease the risk. So my objectives for you today are to understand why and how surgery is performed, understand the typical operative OR course, understand the typical recovery pathway, and to discuss any possible complications and how we can work together to help prevent these from happening. We'll start with the knee. So in general, you have the knee is made up of 3 bones. You have the femur, which is the thigh bone, you have the tibia, which is the shin bone, and then you have the patella, which is the kneecap. A normal knee has a nice thick layer of cartilage in it that provides cushioning between the 2 bones and allows for painless motion between the joints. Arthritis is when you have loss of articular cartilage, and that happens either from trauma or from normal wear and tear patterns. There's different types of arthritis, with the most common being osteoarthritis, and all that means is that you've lost some of the articular cartilage in your knee. There are 3 compartments in the knee. There's the medial, also known as the inside compartment of the knee, the lateral, which is the outside compartment of the knee, and then the patellofemoral joint, which is behind the kneecap. If you have arthritis in only one of these compartments, we likely have discussed a partial knee replacement, where we only replace the part of the knee that has arthritis in it. If you have arthritis in 2 or more of the compartments, I'd likely have talked to you about a total knee replacement at this point, where we resurface the bones in all 3 compartments of the knee. For a partial knee replacement, the most common compartment that's affected is the medial or the inside compartment of the knee. I treat this with a partial knee replacement, which is a really good surgery to help alleviate pain and improve function. I prepare the bones of where the arthritis is by removing a thin layer of bone and the diseased cartilage. Then we put the new implant in and cement it in place using cement, and place a high-grade medical plastic known as a polyethylene liner in place between the 2 pieces of metal. When you have arthritis in more than one compartment of the knee, I've likely spoke to you about having a total knee replacement. Total knee replacement is what we do is we prepare the damaged ends of the bone by resurfacing a few millimeters of bone on the thigh bone and the shin bone. We put new metal implants in place that take the role of the articular cartilage that's been lost, and then we put a plastic liner in between the thigh bone piece, the femoral component, and the shin bone piece, which is known as the tibial component. We also resurface the patella and put a plastic button behind it to allow for painless range of motion of the knee after surgery. Moving on to hip. So the hip is a ball and socket joint that's made up of your femur, which is your thigh bone, your pelvis, and then the ball and socket articulates. The femoral head is what's known as the ball, as you can see in this image here, and the acetabulum is your socket. Similar to in the knee, you do have a thin layer of articular cartilage that allows for painless range of motion of the hip. When you have arthritis, you lose the articular cartilage. You can see in this x-ray here, there's normally supposed to be a big thick space between the ball and the socket, and here this patient has bone-on-bone arthritis in the hip joint, and you can see that they have formed large osteophytes, and there's a lot of subchondral sclerosis. All of these findings are consistent with hip arthritis. The surgical treatment for hip arthritis is a total hip replacement. We perform a total hip replacement by removing the femoral head. We then insert a metal stem into the thigh bone, known as the femur bone. We prepare the acetabulum, also known as the socket, to accept a new metal cup, and then we create a new bearing surface made up of a ceramic femoral head and a plastic liner to allow for a smooth, pain-free range of motion of the hip. We are going to transition now from talking about the details of hip and knee arthritis and treatment into more of what to expect in preparation for your upcoming surgery. I do surgeries at 2 sites for elective procedures. One is our Coastal Ambulatory Surgery Center located at our main office on State Route 64, and the other is at Doctors Hospital located in Sarasota. If you're having a surgery at Doctors Hospital, you'll be receiving a phone call from their staff between 5 to 7 p.m. the day before surgery with an arrival time for you to be at the hospital. If you're having surgery at our Coastal Surgery Center, we ask that you call the surgery center the day before from 2 to 4 p.m. in order to get a time to arrive for surgery. If you're not able to get a hold of anyone at either Doctors Hospital or Coastal Surgery Center, please contact my office directly. If you're traveling in from out of town, please let us know so that we can make sure that you have the necessary arrangements ahead of time. Day of surgery, it's important to bring your photo ID as well as your insurance card. It's also important to have any durable medical equipment necessary for your surgery. We will have discussed this in the office, and there's also some information about that on the upcoming slides. In addition, I will have discussed with you at this point whether you'll be going home the same day of your surgical procedure, which all patients at the surgery center are, or if you'll be spending one night in the hospital, which about half of my patients at Doctors Hospital spend the night, the other half go home the same day. You will need a friend or family member to accompany you to the site of your surgery the day of, especially if you're going home, as you will need to have them there in order to be discharged. I would recommend wearing loose, comfortable clothing the day of surgery, and also to leave any jewelry, money, or significant valuables at home. In addition, it's very important not to eat or drink anything after midnight the day of your surgery. This may change slightly if you're indicated for outpatient surgery. We may have you drink some fluids the morning of, but in general, unless you've been indicated not to and been told explicitly to drink something, do not eat or drink anything as of midnight the day before your surgery. In addition, it's important to rearrange your social schedule and your work schedule to allow for recovery time afterwards, which we've likely discussed already in clinic as to what the standard recovery time after these surgeries is. In general, I do not like you driving for the first 2 to 3 weeks after having a hip or knee replacement. I usually will have you see me at the first post-operative visit, and then we'll discuss if you're safe to return to driving at that point, generally around 2 to 3 weeks after surgery. In general, for physical therapy, we'll have either 2 options for you. We'll either have home health services come out to your house for the first 2 weeks after surgery and be able to do some in-home physical therapy, or we will have you go straight to outpatient physical therapy, and this will be discussed with you immediately before your surgical date. In addition, it's important to avoid any invasive procedures, including dental work, for at least 3 weeks before surgery. If you're taking any of the following medications, it's important to discontinue them at least 1 week before surgery. These include all anti-inflammatory medications like aspirin, Motrin, Advil, Aleve, as well as the newer weight loss medications such as Ozempic and Mounjaro. In addition, we like you to stop all vitamins and supplements 1 week before the surgery. Some of you are likely on blood thinning medications such as Plavix, Eliquis, and those medications. Those will need to be stopped, but the time before surgery will vary, and we'll discuss this with you on a case-by-case basis, working closely with your medical and prescribing physician. After surgery, you will need some durable medical equipment. One thing that all patients require is a rolling walker with 2 wheels. This must be obtained prior to your surgical date and be brought with you to both the hospital or to the surgery center. We can help you provide a walker through you that may or may not be covered through insurance, directly through Coastal Orthopedics, or you can go ahead and purchase these independently off of Amazon, Walgreens, or any other vendor of your choosing. In addition, we do offer 2 optional ICE units for recovery. We have a jet stream or breg unit that applies ice with no compression. My doctor's assistant Tiara can help provide some additional information for you on that with regards to pricing options available. In addition, there is a NICE unit which provides ice and compression. Our Jeremy can help you look into this option should you want it. Both are optional. In addition, you can use just traditional ice bags as well. Day of surgery, we'll discuss the anesthetic component of the surgical procedure. For total knees, my preference is to do a spinal anesthesia with a regional block and twilight sedation. Spinal anesthesia is where the anesthesiologist will do a small injection into your spine that will allow your hips and knees to be numb for the duration of the surgery. They also perform an adductor block, which helps control pain during surgery and after surgery. You will be given twilight sedation similar to having a colonoscopy, so you will be asleep during the surgical intervention and not be conscious of anything that is going on. However, you will be breathing on your own. We've done a lot of research on the topic and find that spinal anesthetics decrease the amount of pain you are in during surgery and after surgery, decrease the amount of narcotics that you take during surgery and after surgery, and allow for a more rapid recovery afterwards. For my hip replacements, I also prefer a spinal anesthesia that we may discuss doing an additional block for pain control purposes, and we do provide the same twilight sedation medications. If you have significant spine arthritis, a history of a previous spine surgery, or if the anesthesiologist feels that a general anesthesia would be better, they will discuss this with you the day of surgery. I close the vast majority of my surgical incisions with a plastic surgery style closure involving all sutures on the inside of the skin with a layer of skin glue on top. A Aquacel dressing is then placed on top of this, which is a sterile waterproof dressing which allows you the ability to shower immediately afterwards. It also has some important antimicrobial properties. In select patients, for example, if you have diabetes, if you smoke cigarettes, or have other risk factors for wound healing, I may close your incision with staples or sutures on the outside of your skin and place a negative pressure dressing on. And if that's the case, we will provide some information to you regarding this dressing and closure type. At day 7, I do ask that you remove the Aquacel dressing. At this point, your incision can be left open to air. You are able to shower and let water run over the incision, but I do not like you to soak your incision or go be submerged in a bathtub or pool for about 3 to 4 weeks after surgery. If there's any drainage from the incision, you can apply a dry dressing and cover it with an ACE wrap or gauze just to provide some compression to the surgical site. I would like you to avoid applying any creams, lotions, or ointments on to the incision until I give you the okay to do so, generally at your second postoperative visit, which will be about 6 weeks after surgery. The day of surgery, you should expect to spend a total of about 90 minutes to 2 hours in the operating room. It takes about 60 minutes to do the surgical portion of the case. However, we do need time to allow for anesthesia to do the spinal block, so make sure we can do the procedure safely, and also to position you safely for surgery and make sure that we get everything prepped and draped in the appropriate position. If you are going home the same day, either from the surgery center or from the hospital, you'll be brought to the recovery room and you will meet with physical therapy. You will get up and walk, and you will shortly thereafter go home. If you're at doctor's hospital and the plan is to spend the night, you will be admitted afterwards to the orthopedic floor, where you'll have a dedicated orthopedic nursing team as well as physician assistants there and available to help you with every aspect of your care. In general, the following discharge requirements must be met. So in order to be discharged, we want to make sure that you're safe mobilizing. Physical therapy will work with you to make sure that you're safe walking, using the assistive device that's provided to you, as well as being able to ascend and descend stairs if necessary for your home. You must be medically stable, meaning your vital signs must be stable, and we must make sure that your pain medications are providing adequate pain control for you. You'll be on the same medications at the hospital as you will at home, so we want to make sure that what you're being given in the hospital will provide adequate coverage. I will send all of your medications into the pharmacy at least 1 week prior to surgery, and it's important to pick these up before the day of surgery. I utilize a multimodal pain control strategy where we use various medications from different families to help make sure that your pain is appropriately controlled and decrease the amount of narcotics that you have to take during your surgical recovery. The pain control regimen will vary on a case-by-case basis, and I will discuss this with you, as well as give you a chart the day of surgery with detailed instructions on how to take the medications. In general, I will have you taking Tylenol 3 times a day to provide some baseline level of pain control. You will have tramadol available to be used as your first line of defense for some breakthrough pain. You will be taking an anti-inflammatory medication, usually Celebrex, once a day. That helps control your pain and decrease scar tissue formation. And then when you have severe breakthrough pain, for example, in the first few days after surgery or when working with physical therapy, you will have oxycodone available to help with your pain control. In addition to your 4 pain medications that were just listed, you'll have a few additional medications to take. I put the majority of my patients on aspirin to help decrease the risk of blood clot formation, so you'll be taking aspirin 81 milligrams twice a day. I do prescribe a stool softener for all of my patients because the narcotic medications can cause some constipation, so we have you take the stool softener while you're taking the narcotic medications to decrease the risk of this happening. The narcotic medications unfortunately do have a side effect of causing some nausea, so I will prescribe Zofran to help control your nausea after surgery. And in some patients who are at high risk for developing an infection afterwards, such as if you're a smoker, diabetic, or obese, I do prescribe a week of oral antibiotics to help decrease the risk of developing an infection after surgery. Physical therapy is a very important part of your recovery after having a hip or knee replacement. If you're having surgery at our surgery center, I do like you to have a one-time physical therapy visit with our therapist prior to the date of surgery to review how to utilize a walker or other assist device to make sure that you're safe mobilizing after surgery. After you've had surgery, I will want you to start physical therapy. I generally do not recommend therapy for the first week after surgery. I want you to spend the first week resting and allowing the muscles and the soft tissues to heal, and then we will start working on your physical therapy. During this time period, you can work on the exercises that they taught you at your pre-surgical visit or that are demonstrated to you at the hospital, but I do not want you worrying about your range of motion, particularly for knee replacements the first week after surgery. In general, I will have you follow up with me 2 to 3 times after your surgical procedure. Of course, I'm always available to you should you want to come see me at any point. More or less frequently is totally fine with me. In general, I like to see you back 2 to 3 weeks after surgery. At this visit, the main things we will be checking is to make sure your surgical incision is healing appropriately, and we'll check x-rays of your hip and or knee replacement. I will then see you back at 6 weeks after surgery, where we'll take x-rays and make sure that you're progressing as appropriately. After that, we leave it a little bit open-ended. I generally see patients back on an annual basis after that to make sure that, to check an x-ray and make sure that the hip and or knee replacement are still in the appropriate position. On my portion of the Coastal Orthopedics website, there is a document with a list of frequently asked questions that patients have, so I encourage you to review this document as well. Some of the highlights for this are: when can I return to work? This will vary on a case-by-case basis as to what your work is. If you're doing a light duty or desk job, I tell most of my patients you can get back to doing that job at full duty 2 to 4 weeks after surgery. If you're doing a more heavy duty or labor-intensive job, this will be about 6 to 8 weeks after surgery. And if you're doing a heavy labor, maybe about 3 months after surgery. In general, I encourage you to ask for more time off and go back early if you're feeling up to it, rather than asking for less time off and having to extend afterwards. When can I return to driving? In general, this is about 2 weeks after surgery. You must be off of your pain medications and feel safe at that time to get behind the wheel. When can I fly? Generally, I like you to wait until after you've seen me at your first post-operative visit. However, this can be varied on a case-by-case basis. Of note, we do not give implant cards out at this time for metal detection or TSA security purposes. When can I return to activities? Generally speaking, at 6 weeks, I allow you to return to full activities and do anything and everything that you want. You're usually about 75 to 80% recovered of where you will be at this point. I allow you to ease into these activities at 6 weeks. So I want you to generally, so for example, if you want to get back to golf, I encourage you to start on the driving range, play a few holes before you go out and do 18 holes of golf. When can I have my other hip or knee replaced? I like to space this out at least 6 weeks between surgeries to make sure that your initial side has recovered and healed well before we move on to doing surgery on the other side. This is an important slide, and I would like to take a moment to review the potential risks and complications associated with hip and knee replacement. We have likely discussed these together at the time we signed up for surgery, but I would like to review these one more time. Infection, unfortunately, is a complication of hip or knee replacement. Fortunately, it's a very rare complication, and we do everything we can to prevent an infection from occurring. Risk factors for infection include if you're a smoker, if you have diabetes, or if you are obese, or if you are on any steroids or disease-modifying drugs for rheumatoid arthritis. We give you antibiotics before, during, and after surgery to help decrease the risk of developing an infection. In addition, another potential risk in the perioperative period is developing a blood clot and pulmonary embolus. We give you a blood thinning medication, usually aspirin, to decrease the risk of this happening. There is a risk of a hematoma forming, which is a collection of fluid around your hip or knee replacement. There's also the risk that over time, your implants may become loose and fail, which could require revision surgery. Fortunately, this is very rare. In addition, you may have some residual pain after your hip or knee replacement. We replace the bony structures, but you still have your soft tissues that are there. So you may have some irritation and inflammation from your soft tissues after surgery, but in general, the vast majority of your pain will go away. There is a risk of having an intraoperative fracture especially with a hip replacement with the stems that we have. I evaluate your bone on a case-by-case basis, and if I feel that this risk is high, I use a different implant, notably a cemented femoral stem, to decrease the risk of this happening. There is a risk of nerve injury, both with a hip or knee replacement. One of the risk factors that increases the risk of developing a nerve injury is if you have a valgus or a knock knee. When we straighten you out doing the knee replacement, it could put some tension on your peroneal nerve, which can increase the risk of this happening. Fortunately, this again is very rare and is usually a transient nerve injury. As with any surgery, there is a risk of having potential blood loss during the surgery itself. This is usually very low, and especially because we use a medication called tranexamic acid to help minimize blood loss during surgery. After a knee replacement, you may have some clicking between when you move your knee. This is normal. It is a metal and plastic implant that we do that functions very well, but it can click from time to time. You may notice a small leg length discrepancy after surgery, especially with a hip replacement surgery. When you have arthritis, you lose your articular cartilage and your limb becomes shorter than the other side. When we do your hip replacement, I plan before surgery and I account for this leg length discrepancy, and my goal is to make it to match the other side. I utilize a computer-assisted program to help make sure that this happens, that this is correct and perfect in the operating room. So this is a very rare risk, but I do want to make sure that you're aware that this is a possibility. Many patients in the first couple weeks after surgery do have some difficulty sleeping, and that is normal. And unfortunately, there are a small percentage of patients who after surgery do have persistent pain in their hip or their knee. There are some common symptoms after surgery. So it is very, very common to have swelling in your entire operative extremity. This is because of gravity pulls the blood and swelling from your hip or your knee down. So you may have some swelling in your calf and your foot, and that is normal. You also may have some bruising throughout the entire leg. The leg may be warm as a result of the body trying to send increased blood flow to the area to help heal your incision. You may have some small redness or irritation around your incision, and you may also develop a low-grade temperature after surgery, which is part of the body's inflammatory response to surgery. Please call my office if you have any questions at any point about these symptoms or if you develop them. Some kind of red flags to be concerned about is if you have significant calf pain that is tender to touch, if you develop a fever over 101 degrees, if you have drainage from your incision, if you have significant pain that is not being controlled with your medications, or if you have increasing redness around your surgical site. Finally, this is a checklist available that we have on my website for you to review to make sure that we have all the necessary preparations in order prior to your upcoming surgical intervention. I'm very excited to undergo this joint replacement journey with you. Myself and my team are available for you 24/7 to answer any questions you have, and we'll do everything we can to make this a pleasant experience for you and get you back to doing all the activities that you like to do without pain at a better level than you are before. Please let me know if you have any questions or concerns.